Welcome and hello to everyone joining today. You are in the NCAPPS July webinar, The 3 Legs of the Stool, a framework for person-centered community mental health services that do no harm. My name is Bevan Croft, and I co-direct the National Center on Advancing Person-Centered Practices and Systems. I will do a quick visual description of myself for accessibility. I am a white woman in my 40s. I have blonde hair pulled up in a bun. I'm wearing a blue dress, and I am in my home office with plants behind my right shoulder and a bookshelf. No, plants behind my left shoulder, a bookshelf behind my right shoulder, and a window, a sunny window behind me. You are joining an NCAPPS webinar. NCAPPS is funded by the Administration for Community Living and the Centers for Medicare and Medicaid Services. Next slide, please, Elaine. And all of our webinars are free and open to the public. Next slide, please, Elaine. The goal of the National Center for Advancing Person-Centered Practices and Systems is to promote system-level changes that make person-centered ideals a reality and not just an aspiration for people who use any kinds of long-term services or supports. Next slide, please. A few logistics before we dive in. This is a webinar format, so everyone is muted. However, chat is open, and many people are already introducing themselves using chat. We're very glad to engage with you in this way. And if you would like to have everyone here see your message, be sure to select everyone in the drop-down menu just above the chat window. Toward the end of the webinar, we will have a question and answer period. So if you have questions that come up at any point during the webinar, please put them into chat. We will be keeping an eye on questions and collecting them up, and we'll get to as many questions as we can at the end of our time together. This webinar is being live captioned in English, and it is also being live interpreted in Spanish. If you would like to access the English captions, you can click the CC button at the bottom of your Zoom screen. And to access the Spanish interpretation, you can click the interpretation button at the bottom of your Zoom screen. That's the world icon. And then once you're in the Spanish channel, be sure to silence the original audio. We have just a couple of polls today at the beginning and end of the webinar, so please be prepared to interact there. Next slide, please. We love to hear from members of our community. So if you have feedback about this webinar, you are welcome to get in touch with us. Our email is ncapps@hsri.org. Just note that we won't be checking email during the webinar. And this webinar is being recorded. There will be a PDF version of the slides, a plain language summary, and a recording posted on our website within a few weeks. And we'll also do our best to include some supplementary materials and question and answer responses as well. Next slide, please. So let's find out who's here. There are hundreds of people here today. If you would, please indicate a role that you self-identify in the poll that has just popped up. If you don't see a role that you self-identify in listed here, please use chat to share what your role is. And you're welcome also to check all that apply. I will read out the choices as folks respond. They are a person with a disability or a person who uses long-term supports, And this could include a person who uses supports for, related to mental health or substance use. You could be a family member or loved one of someone who uses services, a self-advocate or advocate, a peer specialist or peer mentor, social worker, counselor, or care manager, a researcher or analyst, a community or faith-based service provider organization employee, or a government employee, and that could be an employee of a federal, state, tribal, or municipal government. I will give folks just a couple more seconds to respond. Thank you to the folks who are typing in as well. I see recovery coaches, folks in prevention, fantastic, some navigators, some coordinators. All right. So we've got the results of the poll up. 7% of you identify as a person who uses services, and 11% as a loved one of someone who uses services. We have a good number of advocates, 30 peer specialists on, welcome. And then 40%, the largest group here is identifies as a social worker, a counselor, or a care manager. We have a handful of researchers in the house, and a handful of providers, and about a third of you are government employees. Thank you for that. It's great to know who's here, so that we can, tailor the discussion so it's relevant to you. All right, next slide, please. I'd like to invite our lead at the Administration for Community Living, Sean Terrell, to just say a few words of welcome before we get started.
Thanks, Bevan. It's Sean Terrell, Administration for Community Living, and I'm the ACL lead, as Bevan mentioned, on the NCAPPS project. We're in our 5th year. And this, I guess, this webinar is really important to me, and I think ACL in generally, we have really been focused, and NCAPPS has really picked up the mantle on the question of how to engage people with lived experience throughout all of this work. I work in the policy shop, and that really should be driving our work. And so this is we've done a few on mental health. This one I think has its own special focus in that much of the mental health system still, we can argue about how much or whatever, but in general, it's a fairly medicalized system still, and relying on a fair amount of coercive practices, if you will, as well. And what we're trying to do at ACL is supports individuals and systems, and through NCAPPS, to be person-centered, to be trauma-informed, and to be non-coercive. And I think that, there's some contradictions and some challenges when we are coercive. How can we also be person-centered? It's kind of a contradiction in terms, how can we be trauma-informed when coercing people is generally experienced as a traumatic experience? So I've been working with some self-advocacy groups around the country, but also in Ohio, specifically where Ashland County is, which is was the focus of this webinar. And I just want to just call out Christina Kapp, who's been really helpful in Ohio and helped me understand the system there more, and to help me reintroduce myself to Steve today, to Steve Stone, who's going to be the main facilitator of the discussion. And what I would like this to be, and I think we all hope this can be, is a sort of a beacon of possibility when you start to take the contradictions inherent in the mental health system that we currently have and resolve them in the direction of humanity and human rights and civil rights. And I think what you start to get is what Ashland County looks like. And this is one example. I'm sure there are others around the country. What we want to do, and we'll see at the end of the webinar, there'll be an opportunity for those who are interested to engage in more discussion about this, where these pockets are of this kind of approach to supports and services and for recovery. And and how can we replicate this in other communities? How do we scale it at the state and federal level? So that's kind of the creative thinking part of all this that we hope to engage you with, and looking forward to a great webinar. And thank you everybody for joining this. It's really exciting to see so many people.
Thank you, Sean. This is Bevan. If you could skip 2 slides ahead, and we'll just go ahead and get started. And I will do so by introducing Steve Stone. Steve is the Executive Director Emeritus of the Mental Health and Recovery Board in Ashland County, Ohio, where he served as Executive Director for 18 years. And Steve was the primary author of Our Human Community, a resource that really outlines a lot of what we're going to hear about today. And he served as a counselor, administrator, and advocate in community behavioral health for over 40 years. Welcome, Steve.
Thank you so much, Bevan, and to you and your staff and to NCAPPS for hosting us today. And also, I want to say a thanks to Sean Terrell, who's been a longtime colleague, and glad to reconnect with him around some areas of mutual interest. And also to my fellow panelists today for taking the time out of their busy lives to help with this effort all along, and also help and by participating today in the webinar. Can we go to the next slide, please? We're going to cover quite a bit of territory today, but really we're going to be very succinct, and there's a lot of this that we can unpack quite a bit more, and maybe we'll have future opportunities to do some of that. But what I want to do is give you a sense of the system in Ohio, a little bit about the context, what's been going on here, and then we'll get into the framework that we've constructed. But Ohio is a state that operates with a county behavioral health board system. We're not the only state like this, but states have very different ways of operating community behavioral health care. So in Ohio, county boards are established in the law, and they are authorized to plan, prioritize, fund, and monitor services. Embedded in that is a responsibility to protect rights and to establish a culture of care. Boards don't directly serve clients or individuals in the community, but we contract with local nonprofit agencies to provide the services on our behalf. And that really allows us a very good opportunity to help build this type of a culture, because there's a more unified framework in the county between the board and the providers that we can start with. The mental health board, is governed by either 14 or in our case 18 volunteer appointed board members. They are residents of the county, and they volunteer their time. They represent a very diverse members of the community. The board then hires a paid executive director. That'd be David Ross, who's going to be up later on the panel. And then David has a staff of 3 people that work for him. And of course, that configuration changes across the state depending on the size and needs and that of the county. County boards then receive federal and state revenue. Not all of it. A lot of it's going in other directions too, but a bulk of behavioral health care funding available locally in Ohio comes to the boards. That's federal, state, and also private dollars. We get grants from private foundations. We also have an endowment at a local foundation here in Ashland. Next slide, please. That's a little bit about the board. The sort of the context of all of this is maybe a bit bleak, but we're going to try to offer some hope. I don't think this is unique to Ohio, but I'll say that the medical model is very dominant in Ohio. And I think that has helped to fuel the increase in the use of mental health courts, non-consensual treatment, and things of that nature. Funding has become more fragmented. Some of it's now going not to the boards, but it's going in other directions to schools and law enforcement. There is an increased administrative burden because the more you fragment funds, the more difficult it is to administer, report, and manage those. In addition to that, there are more mandates. I said earlier that mental health boards are responsible to establish the priorities, but the reality is that we're third in line for that, because we have to first make sure that we give assurance that we're going to follow the federal priorities and then the state priorities. And then if there's anything left, we get an opportunity to talk about what's really important to us locally, which is oftentimes very different than those other mandates. And so consequently, there's been less local control over the local services. Next slide, please. While all of that has been occurring, there's been some very interesting kind of parallel developments that haven't gotten maybe the type of attention we'd like, but I think they're very important. One was back in 1992, which is now 31 years ago, the Department of Mental Health in Ohio prioritized trauma-informed care. And of course, SAMHSA issued the principles and the white paper in 2012, which have become part of our framework. But this was important because at the same time, many of you remember that was the decade of the brain when brain research was getting so much attention. But trauma-informed care, I think, helped to sort of bring some attention back to psychosocial elements into mental health care. And while they did not mitigate or stop or restrict the growing interest in the use of coercive strategies, it did offer an alternative framework for programs that was very attractive to us. And then there was the development of medication optimization, which was done under the auspices of the Foundation for Excellence in Mental Health Care. And that was convened by Robert Whitaker and helped to establish some guidelines around the use of medications, which is a very conservative approach to the use of medications in mental health care. And then, of course, there's the SAMHSA principles of recovery that were published and widely disseminated back several years ago. Next slide, please. So just want to kind of, we're not going to go through this in much detail, but this is in your slides and you can refer to this later. But this is a chart that has two columns, and the one column on the left is the medical model and some of the things that would describe or define the medical model. And then on the other side is the trauma or recovery model that we're trying to promote. And you can see some of the big differences there. If you look down a couple, I mean, one of the common distinctions is the medical model looks more at what's wrong with you through symptoms and diagnosis and all of that. Trauma recovery looks more to your experience, what's happened to you, what's going on in your life. Recovery might mean symptom reduction and under a medical model, where it means maybe a full life in a recovery model. A big one towards the end there, the second from the bottom, I want to mention, under a medical model, people are encouraged to comply with the interventions that are offered to them. Very different than the trauma model, which is helping people become more empowered to take charge of their own recovery and lives and become more independent. So next slide, please. So that kind of highlights some of the essential differences, and I'm sure none of that is new to any of you. But I want to use this quote from a dear friend and colleague from Ashland, Ohio, who is a well-known advocate for mental health and men with lived experience in trauma. And Pat Risser would say this frequently about his own experience. I don't believe in mental illness. My thoughts, moods, feelings, and emotions are not a disease or disorder or an illness. They are me, the essence of my being and what makes me a unique human being. And so Pat is a big part and inspiration for the work that's being done here in Ashland County. Next slide, please. The next slide is going to show three columns. On the left is the principles of trauma-informed care, and then the middle are principles of recovery, and then finally principles of medication optimization. And I'm not going to go through those in detail. I'm certain you're familiar with at least trauma-informed care and recovery. Medication optimization is aligned with those principles around shared decision-making, but it's also a very conservative approach of trying other things first, emphasizing psychosocial supports, for example, starting with low doses and working up, minimizing drug combinations, close monitoring, very limited duration when that's possible. So it realizes a role for medications, but doesn't allow medication to eclipse all of the other important elements that are so perhaps even more critically important many times for recovery. So next slide. So that's essentially the framework that we did. And it's not rocket science. These are established principles that are out there, but we found them to be articulating a lot of the values that we embrace locally. And so we wanted to bring those three elements, those three sets of principles together, if you were, and use that for the work that we're doing. So having this framework then really helps us to develop a culture of care and services that are unified. There's consistency within our system and among the agencies. It helps the board to direct funds strategically to build the system and continuum of care, looking especially to build those psychosocial supports and offering a much broader menu of choices to offer people in their recovery. The framework helps the board to promote what helps and avoid what hinders. And I want to mention one of the resources in our resource list is a report from 20-some years ago called What Helps, What Hinders. I would, if you've not seen it or not read it for a while, pull it out again. It's a very, very important and good report because we do need to talk about what helps. But we oftentimes we avoid those discussions about what interferes with recovery. And there's a lot of things that interfere with recovery. And we think that the use of force and coercion are perhaps close to the top of the list there. So promoting what helps and avoid what hinders as we make choices about where to direct funds. And avoiding things, for example, like putting a lot of money in children's residential program, into outpatient assisted treatment courts or involuntary outpatient commitment programs and that type of thing. Next slide. So I just want to say that, what Sean had said earlier is really key to this whole presentation and to the framework. And that is, we can't say that we embrace trauma-informed care and the principles of recovery on the one hand, and yet we promote or we allow the promotion and we allow the use of things like outpatient assisted treatment, mental health courts, seclusion and restraint, which is another issue I think we need to really take some strong advocacy efforts to address issues around that. But so anyway, so it's not just about investing in what's important and good and helpful, but it's about avoiding and making it known what kinds of things could be risky. But one of the things that we've done, and then I'm going to wrap up and turn it over to the panelists here, we've taken some of the money that we got available that does not have to be tied to fee-for-services, and we've used what we call a carve-out for those. So we carve out dollars that we can use for developing these more flexible services. And these services, we don't require a diagnosis. We really try to minimize the administrative burden. We make it easily accessible. We've seen some improved outcomes, and we've been able to use a hybrid model where we can sometimes subsidize a fee-for-service program with some of our carve-out dollars to make that more effective. And there'll probably be some comments about that a little bit later. Next slide, please. Some examples of our carve-out programs. Can you back up once? I think, did we skip a slide? Okay, there's a missing slide, no problem. I just wanted to mention some of the programs that we've funded with the carve-outs. Our largest program is a school community liaison program, where we've got mental health workers in the schools all over the county, and they work with kids day in and day out, but it's very much not a medical model program, and no diagnosis, no formal diagnostic assessment, unless there's some real evidence that that's going to be important or helpful. Also, a hearing voices group, and you'll hear a little bit more about that, which is a very good option for people who hear voices, because many times they're offered little more than medication. So this offers a whole range of supports for them. So with that, I'm going to wrap up, and I'm going to turn it over to Jerry Strasbaugh. If we can have the next slide, please. Jerry is the director of the community mental health program here in Ashland, our largest program. Jerry's got over 30 years of experience in the mental health system, inpatient programs, partial hospitalization, outpatient, and so on. For the past 18 years, he's been director of Appleseed and holds a degree in special education, a master's degree in counseling from Ashland Seminary, and a doctorate in leadership studies from Ashland University. So with that, it's my pleasure to turn the microphone over to Jerry Strasbaugh.
Thank you, Steve. And so first of all, let me say that I am a 59-and-a-half-year-old male with salt and pepper gray hair, and I have glasses. I'm wearing a purple tie and a jacket. So first of all, let me say thank you to NCAPPS and Steve for inviting me to be part of the program today. It's a real privilege to be here. I am speaking from the provider organization perspective on how we at Appleseed Community Mental Health Center implement the 3 legs of the stool model. So you can go ahead and advance the slide if you would, please. So just for some framing, Ashland County is halfway between Cleveland and Columbus in Ohio. We're a more rural county, and of course, everywhere is different, and many of you listening may be from areas that are more rural or possibly much more urban. So hopefully what we talk about today will be helpful. But we, again, as an agency implementing the 3 legs model, working with a lens of trauma-informed care, trauma-competent care, using medication optimization, and being recovery-oriented in what we do. So if you could advance the slide, that would be great. Thank you. So as a director of an agency, how do I view implementing this model? I believe that first and foremost, you have to have a theoretical frame to hang everything on. So here at Appleseed, we say that our theoretical frame for operations, we have 2. One is being trauma competent, trauma informed in what we do. And the second is family systems. Hang on a second. So with trauma informed, we make sure that all staff, as Steve had mentioned earlier, think about what's happened to the people that we serve rather than what's wrong with them. And with family systems, we're really emphasizing looking at the relationships in between people. What does the relationships look like that people have had in the past and also in the present? And then this allows us to be holistic and person-centered in what we do. So as I said, I think you have to have a lens with which you build everything through. Could you advance the slide, please? Thank you very much. So just using this pyramid to kind of give you an idea about how we do that. We start with our theoretical frames. We build that into our policies and practices here at Appleseed. For instance, an example is when folks come here for services, in particular services, mental health or substance use services, we ask them to complete 3 sessions with a counselor before we refer them on to a physician or a psychiatrist for medication, simply to help them begin to build a holistic practice before we move on to medication, if that's something that people want to engage in. We at staff meetings every month, we talk about our lens that we work with, being trauma-informed and family systems. So staff get tired of me talking about that, but every month we review how we work here at Appleseed and how we work with people. Then we make sure that we send our staff to trainings, and we provide trainings to our staff that fit the 3 legs model. We avoid trainings that do not fit the model, and we emphasize trainings that do fit the model. So for instance, many of our staff here are trained in things like EMDR, trauma-focused CBT, trust-based relationship interventions, dialectical behavioral therapy. We really try to saturate those kind of practices within our staff so that we can bring those to the folks that we serve. And then finally, when we're communicating to the public, we make sure that whether it's we do mental health minutes on the radio or community education in another way, we make sure that we're communicating that this is how we do things here at Appleseed. And we're, we look at things through a trauma-informed lens, and we're very person-centered. Next slide, please. So then putting that into practice with our team here at Appleseed, we make sure that from assessment, whether that's an informal assessment that maybe our school liaisons are doing, or a more formal assessment that we're conducting with someone here at the agency where the counselors are located, we make sure that people are asking questions and intervening through a trauma-informed lens, looking at their life, what's happened to that person, and also really emphasizing the relationships that that person has in their life. We look at diagnosis as sort of more of a billing code, I guess I would say, something that we may use if we're going to be using insurance or Medicaid for that individual, Medicare. We know that that's important for those kinds of things, but also we make sure that our staff see that as not the identity of the person, but just something that we use technically here as we work. And then finally, programming and treatment planning. We emphasize group treatment. Right now we have a lot of groups going on this summer, art therapy groups outside in the park for individuals where the weather's good. We try to, as much as we can, emphasize holistic treatment in the treatment planning process. Again, not that we don't refer to our psychiatrists here practicing at Appleseed, but we also emphasize other things as well. So it's not just that single medical model in the work that we do. Next slide. So then funding the 3 legs model for an agency, how do we do that? So I have an inverted pyramid here to help you see how we think about that. So first and foremost, especially for things like counseling, case management, psychiatry, crisis services, when we can, we will use insurance and Medicaid resources, or through our mental health board, local purchase of service, which is for folks who live in Ashland County who may be indigent, works similar to an insurance for them. So we certainly use those, and those are a big bucket, and those are our primary funding sources. But then we also use, through our contract with the mental health board, local tax investment, local dollars for things like our school liaison program, and then also to supplement people's services. And for instance, somebody might be in our supported employment program. Well, that's going to be funded partially by the mental health board and partially by some state dollars and partially by some other maybe local dollars. And then lastly, we look for local foundations for small things that we can get resources for to help families that may need food, clothes, shelter, or other kinds of things. Okay, next slide, and last slide, I believe, for me. So here's some examples of I'm calling them carve-out funded programs. These are funded programs that are either fully funded by the mental health board in many ways, or are braided together with other sources. So Steve mentioned our community liaison program, school community liaison program. That is funded predominantly by the mental health board, but also more recently, our local school systems have been partnering with the board to expand that program. That allows us to see students in our local schools without a diagnosis. The emphasis of that program is to help students improve their grades, improve attendance, and also reduce behavior referrals to the office. Sometimes we will tap into local foundations or local programs for things that meet specific needs for families. For instance, this year I think we have a local grant for crisis kits for families that have a crisis that might provide some things for them to benefit them. Steve mentioned also the Hearing Voices group that is completely funded by our local mental health board, And that's a program that takes a unique approach, a non-medical model approach to psychosis. So for someone who's having an experience of hearing voices or unusual thoughts, those kinds of things, rather than look for medication to try to stop those things, that group looks for finding meaning in those experiences. We have a program that we call IFAST, Integrated Family and Systems Treatment, that is specifically designed to help out-of-home placement for youth. That program is funded with a combination of things. Ohio Medicaid, when we can bill that for students, for youth and families. Also, the Mental Health Board offsets some of the cost of the staff in that program, and also some of the consulting that we use in that program. And then also sometimes local dollars. United Way may help us with specific needs for some families. And then lastly, the program I would mention is our supported employment program. I think I saw a question from the group about employment, but we at Appleseed believe that work is recovery, and we want people to have meaningful employment and doing things that give them a sense of value and purpose. So with that program, partially funded by Medicaid, when we can use Medicaid for case management services, we will. Our local mental health board, through their resources, helps fund staffing for that program, partially funding some of the staffing. Our in Ohio, another department, Opportunities for Ohioans with Disabilities. If we can have a person who could get some support from them, that's another way to offset that program. And then there's the last several years, there has been some state grant dollars to help fund that program partially. So that's a program that's a great example of about 4 different streams of funding helping make that program what it is. So with that being said, I am going to move on to our next provider, Dr. James Mooney. Or Stacy Roberts, sorry.
Yeah, sorry, Jerry. Stacy's going to be up next. So Stacy is somebody who lives here in Ashland, been born and raised here, and she's got her community supports here, and she facilitates 2 local support groups, Celebrate Your Mind and Part of Me, and she'll be talking more about that. She's a licensed social worker. She's been practicing in the field for 29 years. She's been certified and recognized as a peer supporter by the state. She has lived experience in mental health and recovery, and enjoys sharing her experiences in promoting recovery. So it's my pleasure to introduce Stacy Roberts.
Hi, I'm Stacy. I am wearing a green shirt. I have glasses. I am excited to talk to you folks about my personal experience with lived experience and utilizing the 3 legs of the stool. It's my testimony in terms of trauma-informed care. I've been since age 19 diagnosed with paranoid schizophrenia. So for 25 years in the medical model, that has been my focus. I was Stacy Roberts, the paranoid schizophrenic. And although I was a social worker and worked in the field, that was always on the back of my mind, that was part of my identity as to who I was. And for many years, I carried that burden and shame because of how the how the world views mental health. And I really didn't want anyone to know that I had that diagnosis, and I tried really hard not to promote that for myself. I was living in a town, I know I'm from Ashland, but there was a point in my life where I was living in a different city, not far from Ashland, and I attended their mental health gathering groups. And one of the activities that we had to do was, as we sat in a circle, we had to go around the circle and identify with our diagnoses. Again, the medical model in terms of, hi, I'm Stacy Roberts. I'm a schizophrenic, paranoid person. And then the next person would go around and they would all introduce themselves by diagnoses. So I didn't have a framework of anything else different than that. I knew that, I mean, my self-esteem went very low for that, because I'm like, that's who I am. In fact, I had an opportunity for counseling, and this lady who was going to be my counselor was all excited. She said, I'm so excited that I get to work with a high functioning paranoid schizophrenic person. And I'm like, okay. And I had to process that. And so, very much, yes, I came to realize that 25 years later, from age 19 to 44, which I was pretty much living by my diagnoses, with not much trauma informed anything in my life. However, when I was here in Ashland 7 years ago now, the Mental Health and Recovery Board put a program on with Karen Taylor and Ron Coleman. Ron Coleman is a voice hearer, and he and his wife, Karen, from the UK, came to Ashland to speak. And I had an opportunity to go to their seminar with the encouragement of Trish Risser and so forth. And at that seminar, when they started talking about it not being the medical model, that I can have an alternative story, an alternative way to look at my voices or look at my experiences as not being unique, a commonality with others, that I really broke out of my shell of I'm my diagnosis. I can remember during that seminar, and Karen came up and put her hand on my back shoulder. For the first time in my life, I felt like I'm Stacy. I'm Stacy who, yes, has experienced personal complex childhood trauma, an adult trauma, and that my voices and that my experiences had meaning and purpose, and it wasn't my fault. And so during that time of hearing that, and that just real big paradigm shift in my thinking that goes along now with the 3 legs of the stool, I started to have recovery, and resiliency came about so much more, in that, as they've mentioned, the Hearing Voices Network USA, I was able and had the privilege to go to Columbus, Ohio, for a training on Hearing Voices Network philosophy, and so then being able to 7 years ago promote and work with those folks who have voice hearing experiences, and also might have alternative ways of dealing with their diagnosis, that we do not have clinical language. We don't use terms such as psychosis, delusion, or paranoid, anything, because it's the person, it's person-centered, peer-centered. So although I'm a social worker and I hold that group, I'm also a peer, and how peer support with one another. And there have been times where folks were going to go in the hospital, but because of the group, they did not. Also, too, some people who there was a gentleman who decided, now I have a framework for my voices, and he used a unique way, in a spiritual way, to deal with his voices, that he stopped coming to group and he got a job and he has his own home. Whereas before, prior to that, he was overly medicated, couldn't get up, couldn't communicate with his family, and his life, was very, very much on hold. So there's such value. There's so much value in peer-centered, peer-supported programs that I can't express how much it is very helpful. I grieve when the 25 years that I was in the medical model. It was a time in my life where I was not able to have children, and even though I was married, and it was just, it took away my life spark. So I'm devoted to end the rest of my life cheering on peer support and programs such as those that support the 3 legs of the stool. So again, in recovery and resilience, I was able to go to Scotland and meet up with Karen Taylor and Ron Coleman and participate in their recovery house that they have, their recovery programs. And also too, I had an opportunity to speak with along with Karen Taylor at one of her conferences in Wales. I was her co-speaker. So I'm excited what God's doing in my life, and looking forward to other opportunities for advocacy and an opportunity to share my story. And it's just, just a little tidbit of what I have, been through and endured and continue to persevere through. The other thing too, I so much want to emphasize the medication optimization as paramount throughout my life, because I didn't really believe I was paranoid schizophrenic, but then yet I did at one point. I kind of took myself off medications or worked with a doctor to try to get myself off medications, which really plummeted and did not do well. I was, having rebound psychosis and all those things because of that. But I'm now at a point in having open dialogue with my psychiatrist to have the best optimization of the medication. And just a turn is that because I was on for 31 years on psychotropic medications, now I'm starting to get the physical illnesses that come with that, with your metabolical rate being compromised. I'm now diagnosed with, and I'm not these diagnoses, but it is a subset of being on medication for 31 years where my I'm diabetic, my liver is compromised, stage 3 fibrosis, and I just found out I have kidney stage 2 disease. So I'm working with my physical family physicians along with the my psychiatrist so that we can kind of converge in things that would be helpful. I like to see more work done with physicians and psychiatrists working together as peers with their clients or their patients. So thank you. I have more to say, but I appreciate your time and hope that gives you some enlightenment of an actual person dealing with the opposite end of the 3-leg stool and one who promotes and works and thrives with that stool. So thank you.
Great. Thank you so much, Stacy. I think there's some great examples in there of what sets this sort of framework apart and how it's been helpful to you. Our next panelist up, we can go to the next slide. I don't know if we have both both in bios next to each other here, but we're going to have kind of a co-presentation. We're going to start with Dr. Jim Mooney, who's a physician we've known in our community here for many years. He's been a great collaborator. He has got great interest in the ACEs study and in the effects of trauma on physical and emotional health, also the effects of emotional health on physical health. Lots of experience in a lot of settings, and really honored to have him part of the panel today. With him, can we go to the next slide? It might be Trish's. Otherwise, it'll pop up later. Trish Risser has been involved with peer support for more than 20 years. It's her life's passion. She is a certified peer recovery supporter, actively involved in peer support. She's completed several leadership programs and seeks diligently to help evoke the leader in others. Strong advocacy for the autonomy and choice of those who are often marginalized. She likes being a team player, but she does not shy away from letting her voice be heard when she's standing up, especially standing up for the values and principles of others. So with that, I'll pass it on to Dr. Mooney and Trish, and they're going to kind of do their co-presentation here.
Great. Thanks so much for having us both. So my name is Jim Mooney. I'm actually a 55-year-old white male physician. I'm wearing a blue and white pinstripe shirt. and I'm sitting amongst friends and colleagues in a setting for the community support groups. Trish.
I'm Trish Risser. I'm wearing a purple, I think it's purple shirt with a black, whatchamacallit, and I'm a gray-haired older woman. I won't say how old, with glasses. So that covers me.
Thanks, Trish. Next slide, please. All right, so we called this patient voice and choice because much like Stacy's story, this is actually a practical example of the application of trauma-informed care. And so this is going to be an opportunity to share what Trish and I did together and learn from each other. And we're hoping that this will apply to some examples for your own lives and your practices. Next slide, please. This is just a summary of our interests again. Next slide, please. So we always start with Pat Risser. Pat happens to be very closely known by my friend here, Trish. She was married to the man, and that's how we met each other. So I can't say enough about him. So please remember that this is really the foundation of why we're here. Next slide, please. So just to give you a real quick background of how this happened, and there are some little details in here that I want to convey to the group, because the perspective that Trish and I bring is a little different. Trish was a patient, I was a provider, but Trish also became my mentor, and then I became her support. So it was a complicated relationship that developed over time. But how it all started is I was in Columbus giving a lecture on the impact of the adverse childhood experiences study and trauma as it relates to chronic medical illness. And Pat happened to be in the audience and came storming down the aisle after I was finished and introduced himself to me. And I put in there that Pat invited me to meet him and Trish. And that was a very important part of my journey, because I'm going to challenge each one of you to make sure that you need to go out and invite people that look interested in this topic. We have to be drawn in. We also have our own insecurities as to what keeps us from discussing this. And Pat was very good about, quote unquote, inviting. He brought us in with full steam. And so then we ended up meeting at the Mental Health and Recovery Board in Ashland County. Next slide, please. This is just the overview. I want to talk a little about trauma-informed care and then how we help each other and others find their voice, talk about some of the tools, and then hopefully it'll apply to finding one's voice in their own choices. Next slide, please. All right, so this was shown earlier, and unbeknownst to us, Steve had used the same slide, so it'll tell you how much this man and this message impacted us. Next slide, please. All right, so I'm going to talk a little bit about trauma-informed care because this is near and dear to my heart. So one of the questions in the pre-registration asked about which leg of the stool is either most impactful, most important. For me, it was this, primarily because if you think about trauma-informed care and then resilience and medication optimization, if you treat every individual as a unique person who has incredible value, and you treat them with emphasizing safety, empathy, their voice and their choice, being careful about the language you use and always being kind. These seem like very basic things that we could do to each other as humans, but unfortunately, the medical model that I lived in, I choose to say lived because I choose not to do that anymore, was very much antithetical to these kinds of messages. So that's where my invitation to the Mental Health and Recovery Board and things like asking questions, what happened to you, as opposed to what's wrong with you. That was an incredibly insightful opportunity for me to change my practice. And while it does take time, Trish and I probably developed this over many years, it was also an incredibly impactful opportunity. Next slide, please. I'm showing two pictures. It's much easier to practice trauma-informed care in a setting like this. Next slide, please. And much more challenging to be in these situations, where on the left we have young children in a refugee camp, and on the right, a man who is pictured as homeless and having a lot of difficulty, maybe financially, emotionally. But we have to remember that at the base of every one of these stories is the person, the human being that matters to every part of this interaction in the world. Next slide, please. So I'm going to ask Trish to comment on a couple of things that she's experienced and some of the obstacles that you see when you're trying to find your voice.
So I'm a peer supporter. And one of the things that I do is advocate for other people and encourage other people to advocate for themselves. Because without speaking up, it's never going to change. The system is never going to change. So I sat down and I thought, what are the obstacles to speaking up? And I remember when I needed, the one time I recently needed to speak up, and I was really afraid of speaking up because what would be the obstacles? And I came up with, I was afraid of retaliation or retribution or being bullied, because when I had been, from the time I was 11, I've been in and out of services. And these things did happen. I got ridiculed for speaking up. I didn't have the self-esteem. People didn't listen to me. I thought, I was just so afraid that well, the truth of the matter is I did not have a voice. And when I did stand up for the abuses, not only to me, but to the people around me, I was called a liar. I was told that I didn't understand what was going on, and this was the way it was done. And I was exaggerating what was going on. And at that point, I just shut down. I stopped speaking. And there wasn't anybody to listen anyways. So when I came to Ashland County and there were people who actually listened, it was quite shocking. And I learned to speak up, because without speaking up, the abuses that were going on would keep happening. But I did understand why people didn't, because for years I didn't. Next slide, please.
Perfect. So in light of that, we would like to tell a brief story about how all this culminated together, how I was drawn in, how Trish taught me of these things along the way, but then ended up facing a very dramatic chronic medical issue that required urgent attention, and how we kind of supported each other. So if you don't mind, Trish, talk a little bit about the notification about what happened. Yes.
Okay. So what happened is I had just had surgery and had a transplant on my liver and kidney. And the physician's assistant who called me up asked me if I had gone for a blood test, and my car wasn't running, so I couldn't go. And he came, for some reason, he just came unglued. And he asked me if I was really interested in recovery. He asked me, he told me that I was acting like a baby. And he did say one thing that just took the heart out of me. He said that the team regretted giving me the kidney and the liver. And if you knew me before, one of the discussions me and Jim had was, I wasn't sure I should take the liver and the kidney because maybe some young kid needed it. Maybe a young mom needed it. I wasn't sure that I was the right person to receive that. And I talked to Jim about it because I really wanted to make sure I was making the right decision. Because I certainly knew what it felt like to be in this position. And I hated to see kids go without a mom or a kid, and my blood type wasn't common. So,
yeah, so keep in mind, in the background of this, in the preparation for the amount of work that Trish had to go through emotionally to make that decision,
right.
we were also learning along the way about each other. We were learning about how I had to support her now, not as a medical physician, but as a person who understood some of her trauma. And so I was actually trying to balance both of those. And then as we talked more and more about it, we thought about vicarious trauma, because people who are providers are also patients at times. And so I would ask the group to consider that in the equation. there are people out there, physician providers, and interestingly, the vast majority of this is probably taken care of at the primary care level, not so much with psychiatrists. We know that a lot of emotional health is taken care of in the primary care office. But when we get to this subspecialty area, we have to remember that these people are struggling as well. These providers are struggling. And so I asked Trish to consider that. And fortunately, from her insight and experiences, she was very quick to recognize that and almost be, compassionate and understanding to the person that was actually providing additional trauma to her. Next slide, please. So just real quick, well, I think this is a really important topic. I saw this on the NCAPPS website. They were talking about pressure. And so I think this is so applicable to what Trish and I were going through, because if without pressure, there isn't going to be change. And so this notion of compliance pressure, this was on a blog by Michael Small. It was a great read. So if you have a chance, take a peek. But what was interesting in the compliance pressure notion is there was a deadline. Trish needed a liver transplant. This was not something that we were going to have time to really sit down and think about over a long period. Fortunately, we had done most of the work together about it. And then the positive pressure was, I think, most importantly, we came to an agreement and it was desirable, right? So we were on the same page.
Let me tell you about this agreement. The agreement was, Jim advocated for me all throughout the whole process of getting this liver. And I let him because, I was scared to death to advocate for myself. I've never been able to. And so Jim said to me, you're a peer supporter, right? And I said, well, yeah. And he said, and you want to be able to tell other people how to support themselves, right? And I said, well, yeah. And then he said, well, don't you think you might want to do it yourself? And it's like, no. But then I thought about it. My motto with the groups have always been, I will never ask you to do something I won't do. So here I've been advocating for people, teaching people how to advocate for themselves. And here I was in this horrible situation where I had to advocate for myself. And maybe they would kick me out of the program. And maybe, and the fear started building. And I thought about it and I thought about it through the night. And I thought, he's right. Yeah, I have to do this. I will never know what this feels like unless I do it myself. So I called up and nobody answered the next morning. And so I called again and nobody answered. And so the third time I called, I left a message on the answering machine. And what I said was, I don't want this person to call me again for any reason. I don't want to see this person in the office. He was really abusive and it's not negotiable. And this is how I feel. And I kind of hung up the phone after my little spiel there. And the next time I went into the office, the surgeon said to me, well, so-and-so said that he was pretty abusive, but I just want you to know he was having a bad day. And I thought to myself, boy, I get it. I've been having a bad year. So, but I was so grateful that this guy admitted he was abusive. I was so grateful because, not many people have the courage to stand up and say, yes, I did this. I'm going to own it. And so because of that, I think it was a lot easier to forgive him and to move on. And also the biggest part of this whole thing is after I was done with this, I felt powerful. I felt like I could stand up for myself. I felt like I really know how scary it is to stand up for yourself. And I really understand the fear that's combined to make people stand back or not stand up. It's terrifying. And so I have an incredible, better understanding about what all this is about. And because of that, I am a better peer supporter. And I hope I can help other people with my story stand up and speak out. Because in order to affect change, we're going to have to stand up and speak out. And in all my years of being in the system, being in Pathways and being a peer supporter has been the thing that's helped me more than medications, more than therapy, more than anything else. And I would like to see this kind of program continue. And not only that, but it really helped me learn how to speak to Jim and be a person to him, and him be a person to me. And same with Steve and Stacy. You know, this has just been such a difficult experience, but such a great experience. So thank you all for listening to me. Next
Great.
slide.
Next slide, yeah.
Yeah, this is just our local and national resources. Out of respect for time, we'll move on. Next slide, please. And then please just remember that it's when the person being heard and the person being listened to, both the provider and the patient, are in harmony. Next slide, please. And then obviously, if you want to contact us in any manner, we'd be glad to hear from you. Thanks, Steve.
Yeah.
Great, excellent. Thank you so much to both of you. We're going to keep moving ahead. We have one more presenter here to wrap things up. And I know you'll want to hear from David Ross. He is the director, the current director here at the Mental Health and Recovery Board. Can we get the next slide, please? He's been at the board here for since 2004, director since 2001, which was following my retirement. David and I had a chance to work together for many years, and I appreciate those opportunities, and he's been a great colleague. David works with the agencies and community partners around the ongoing mental health, drug addiction needs of the county. David has got his bachelor's degree in psychology and a master's of education in community counseling from the University of Akron. Before I introduce David, who's going to describe himself, I failed to describe myself earlier. Steve Stone. I'm a retired white male with gray hair and a beard and glasses. I have on a dark blue shirt. So with that said, let me turn it over to my colleague, David Ross.
Thank you very much, Steve, and I really appreciated all the other panelists and this opportunity to share. And as Steve said, we worked together for many, many years, and I have been a beneficiary of that relationship. I am wearing a blue shirt. I have a pink tie, glasses, and I am middle-aged white male. Next slide, please. And we are still going to have time for questions. So I know there's a lot of questions out there. So I will get through my 2 slides here and we will move over to that. So you've heard a lot about some of these out-of-the-box programs that we've been doing in Ashland County. And that's because we've had some flexible funding. Now, I know we're talking to folks from a variety of different states and countries. So I think it's important to try to find the flexible funding that's available to you. In Ashland County, it's kind of unique in the Ohio system. We are able to have property tax levies if they pass, which we've been fortunate, and many of the counties in Ohio have property tax levies. And that's that flexible funding that allows us to do the things that Jerry and some of the other folks talked about. So again, offering services that don't require a diagnosis, that don't require folks to emphasize the medical model, that they can just do what is needed in the schools without a lot of hoops and things that get in the way of accessing services. But the other thing, I've been trying to monitor the comments in the chat. You know, everything that you've been hearing today from the speakers is not something that just happened. This is the end of 20 years of work, of relationships, of building. So I heard and read several comments in the chat. This is going to take some time for some folks to develop, but it's worth doing. I hope you heard from Stacy and Trish, you know, how important this kind of system, this different way, this emphasis on socio-emotional elements as opposed to a predominance on the medical or the biological, how important it is. When we invested in these programs, we noticed that the traditional, what we call fee-for-service Medicaid services, more the biological medical model emphasis, we didn't need as many of them. So whether that was hospitalizations or other services, we noticed that the need for those traditional services went down, which actually freed up money to invest more and more in these non-traditional services. So that was a very nice outcome, and we've continued to see that. And but But this next point, there's a constant need to make the case for these alternative approaches, and you probably know why. Our little board does not have the kind of budget that maybe some of the other organizations that promote a medical model do. So we cannot compete with some of the television ads and other ads that are out there. So I find myself and my colleagues constantly needing to make the case for why alternative approaches to the predominant medical model are necessary. And I point to our little county and people like Stacy and Trish to say, it works. But you do need sufficient buy-in. So whatever group you're working with or you want to work with, you have to start with a sufficient buy-in of folks that are like-minded and that, quite frankly, folks that are in it for the long term. Because like I said, this does not usually happen quickly. I will emphasize that I think it's important to focus early on prevention. You may not realize some of the benefits of a focus on prevention right away, but you will over time. So again, as we know, prevention is one of those slippery things to measure at times, but in our community, because of our emphasis in the school community liaison program, we've seen some of those long-term outcomes now since that program's been around for 20 years and is very much worth it. So I do want to emphasize a focus on prevention. And then this last bullet point is in professionalization of care. I love that. You know, we're trying to move away from professionalization of care. We want to mobilize local community and natural supports. And this is the missing element. And quite frankly, depending on your community, I think it comes naturally to people to be a good neighbor. They just need to be empowered to know that, no, you being a good neighbor or a good family member or a good friend is probably more effective than some of the systems of care and approaches out there. So we very much try to work with our faith community and other community groups and mobilize them to help us and to support us with the folks that are in the system, if you will. And I put in this connectedness correlates with wellness. I think we saw this during the pandemic so starkly. When folks became disconnected, they struggled. We all struggled. So keep in mind, whatever approach you're focusing on, try to emphasize how can we increase connectedness amongst the folks in our community. Next slide, please. A few things here just on the effectiveness that we've seen over the last 20 years. Again, very low use of our state and private hospitalization. And for our county and our state, folks don't end up at a state or psychiatric hospitalization. That's our most restrictive level of care. So if someone ends up in that level of care, we see that in our community as a failure. We have not noticed quick enough. We've not done enough to assist that person. So for us, every time we have a hospitalization, we kind of do a deep dive into why that happened. How did we as a system fail that person and that family? And that's over time has helped us to reduce our state and private hospitalizations to a minimum. We very rarely need to utilize that option. It is there when it absolutely is needed, but very rarely do we have to use it anymore. Same thing with involuntary outpatient, forced meds, guardianships. Again, these are not things that should be routinely done in a system that is trauma informed. Hopefully that makes sense to everybody that's on this. So we very much do not endorse these things. We do not do these things. We have not found the need to do these things, which is the more encouraging thing because of some of our out of the box approaches. But more importantly, I think the philosophy behind the three legs of the stool. Now, I did want to hit this before we go into questions. There are challenges. So if you start down this road, there will be challenges. There will be pushback and there's going to be pressures. For Ohio, I can tell you our funding from the state and the feds has been fairly stagnant. And as you all know, it's just getting more and more expensive to provide the same level of services. So if you have flat funding in that environment, you know, sometimes it's very challenging. In our state, we have a local control where we have these 50 county boards that really are responsible to oversee services, behavioral health services for the county. But unfortunately, we're not getting quite the partnership with our state statutory partners that we'd like to see. In trying to build a bigger tent, a lot more of the resources are going outside of boards. And that just lends itself to some degree of siloing and fragmentation. So boards are having to work particularly hard in Ohio to coordinate all these different streams so we can realize the maximum benefit, and we don't have such a siloed system. And again, I mentioned some of those other systems. Some of these are specific to Ohio, but you might recognize organizations, like Medicaid. So, for example, rates to Medicaid services might increase, but the same services that are paid through boards for the same service, but for individuals not eligible for Medicaid, we're not seeing an increase, right? So that puts us at a disadvantage. Also, there's just been a rise in primary health and direct contracting with agencies as opposed to working with boards. And then this last point, going against what people think we know about any causes of mental illnesses. So this is the messaging that we're constantly trying to refute to some extent or speak into, this idea that we understand what a mental illness is, we can diagnose it in terms of things like chemical imbalances, et cetera. And the effective messaging of some of these, what we would consider to be myths, has been so effective. So often we have to help folks maybe see what's going on and what they're experiencing emotionally or behaviorally in a different way. So we have to overcome this from the outset. And that is just a challenge. I think you all know what I'm talking about. There's a lot of money being spent to tell folks that certain medications will help restore some kind of balance, and that is what is useful and helpful. And really not much is said about relationships and connectedness, et cetera. So I know we're running a little long, and I know we want to get to questions. There's so many good ones out there. So at this point, if I could, I'd like to turn it back over to Bevan, and she can help facilitate the Q&A section of our talk. Thank you.
This is Bevan. Thank you so much, David. You went through a lot of information in a short period of time. Before we jump into Q&A, I just want to have everyone rest assured, because there is such dynamic engagement in chat. Rest assured that if you'd like to engage further with this group is very keen to engage with you. And so Sasha is putting the link that that is on the slide here into chat. So it's a live link. If you're interested in further connecting with this panel to really talk through how can you implement this work or move toward this work in your own state or tribe or country, this group has generously offered to sort of have a more interactive discussion with you. So if you're interested in taking part in that discussion, please simply click on the link that is in chat here and fill out the form. And if you have any trouble with the form, hopefully the form will work for most folks, but if you have any trouble with the form, you can message Sasha here or send an email to NCAPPS@hsri.org, and we'll make sure you get connected. Okay, so I'd like to, we can take the slides down, and I'd like to invite our panelists to turn your cameras on. And let's spend the remaining 10 minutes on a couple of the questions that we have. So in addition to the questions in chat, we received, 100 questions through registration. And one of the common themes that I noticed in the questions that were submitted through that process were any insights that you could share about how this approach that you're describing works, particularly for populations that may have high levels of support needs. And so these could be folks who, in addition to having a label of a psychiatric diagnosis, also have a developmental disability, folks who are unhoused, folks who, have multiple medical concerns. I'm sensitive to the fact that a lot of the more progressive approaches to mental health can be criticized as, supporting only the quote unquote worried well. And so I'd love it if you could speak to that and sort of how you've seen this work for people with a range of different needs.
I'll start, I guess. At our agency, one of the things I always say to our team is that we're only as strong as our partnerships. And so I think it's important for agencies to partner with local other organizations. We work really, really hard. We say we want to be the best partner you have. So we work closely with our local court system. We work closely with agencies that provide housing, food, shelter, Appleseed, where I work. We have a domestic violence shelter. We also have some housing grants, but we work closely with other community agencies that provide those kinds of things, and collaborate and try to plug people in and keep opening doors until folks have what they need. And it is part of being holistic and really helping people meet all their needs. You'll find that our mental health gets much better when you have a house to live in, right? So yeah.
Thank you, Jerry. And I think I saw the Pathways group come off mute.
Yes, I wanted to make a comment and maybe ask Trish and Stacy to weigh in, but your point is very well taken. But our approach is really to try to reach out to the most serious situations, if you can, and people who have struggled the most for the longest. I mean, our focus really is trying to go to people who are in and out of the hospitals and in and out of the jails and living on the streets, and that's our priority. Now we want to be as inclusive as we can, but that's where we want to start. So we don't shy away from that, and we're not looking for low-hanging fruit. We're looking for the stuff that's way up at the top of the tree, because you know what? There's enough stuff out there for the worried well. Worried well are the ones that are being as victimized and traumatized by all the coercive practices that are going on in our system. So those are the folks that we really want to reach first. And I don't know if either Stacy or Trish want to talk a little bit about that. But through your experience, I would say that probably holds true.
Exactly. In fact, Pathways is a peer-centered, peer-run program that is instrumental in helping individuals like myself and Trish to be a support. And in the long run, or even in the short run, to have that support instead of going to the hospital. And in personal experience where Trish was a peer supporter for me recently, even it turned out that support and that peer support proved effective for me, that I didn't have to run to another outlet or agency that would be in the long run more detrimental to my mental health than having had the support from a peer.
And I would like to say that we do have some people here that weren't really welcome other places, but with having lived experience, which I think is almost critical for people, we were able to change that around. And those people are doing really well. I'm so grateful to say, and they're grateful to say. And we try to make some fun here, because mental health is so serious all the time, and we don't get a lot of fun. We dig into that painful experience, and so we try to make it fun. We joke with each other. We bring meals in. We just try to make it as comfortable and as safe, and people really respond to that. So I'm very grateful for Pathways. Thank you.
This is Bevan. Thank you so much for that. And I love that. Let's have fun. We all should be having fun. Thank you. We received a question in chat early on, and a number of other questions that reminded me of a number of other questions we received in registration. Lily asked early on, as America becomes more diverse, how these resources been translated into languages other than English. And I'd like to take the question a little further and bring in some of the other questions that we received in registration, which is really, how can these practices that you're describing be implemented in communities of color, in LGBTQ plus communities, for people with other disability identities? So, and really thinking about kind of how diversity, equity, inclusion, and justice fit with the model that you're describing, recognizing that Ashland County is 96% white, a rural county. So you have the lens that you have, but any thought that you've given to whether and how these practices can be tailored to be responsive to different communities, or whether there's work to do there?
Well, I guess this is Steve, and my initial thought is, this is really not any kind of a sophisticated model. This is a very simple foundational model. I mean, all we're doing is we're saying we believe in trauma-informed care, we believe in recovery and resiliency, and we believe that medications may play a role, but not a primary role. Okay, that's the basis. Now take that and fully embrace it and go with it, because then what you do, if it's based on those principles, that's how you implement it. It's I'm sorry, but I wish I had a nice package I could sell you and come in and charge you a lot of money to develop your program. But it's really pretty simple. It's just embrace the basics, and if you do the basics right, the other things follow. And if I know we don't have a lot of time, but I'm going to use a sports metaphor. In a sports metaphor, let's say, and I'm not an athlete, but I know enough to be dangerous. So you got a batter up there and he's having a bad game, right? So they take him aside and they get the batting coach with him. The batting coach doesn't look for some kind of a new sophisticated bat or some new kind of glove that he's going to, no, they take a video and say, how are your feet? How are your legs? How are your hips? Where are your grip? Okay, look at the basics. We don't have to look far out. If we do the basics right, I believe that many other things will naturally follow. And it's really not that hard. It just takes a lot of will, it takes persistence, and it takes a collection of people that you can work with, because you can't do this alone.
And can I say something real quick?
Please.
And one of the things that we do is we listen, and we go to where the people are at. And for me, it's not a 9-to-5 job. Somebody's calling me at 10 o'clock at night and I'm awake, I will pick up the phone. And I think that's a huge part of it, is being available when the person needs help the most. And I know that's kind of frowned on, and that's why I'm a volunteer instead of a paid employee, because I can pretty much, be there for people when they need me. And I like that. I think that makes a big difference. And I'd like to see peer supporters like me have shifts so that it's not just a 9-to-5. Okay.
Thank you, Trish. Fantastic. I love that. Yeah, that's the fundamentals, right? To continue the sports metaphor. And it sounds like, Trish, you're also talking about the beginnings of cultural humility, which we can think about as a basic practice. So much more to say on that topic and every other topic. I just want to thank, first, to thank our amazing panel. Your work is shining through in this presentation, and thank you to the engagement of our friends here, hundreds of you on chat. I can't wait for the future conversation. I can't wait for us to kind of continue to think about how these principles that you're describing can be incorporated more into NCAPPS work. Big thanks all around to everyone for joining in a summer holiday week to talk about some really important stuff. I hope everyone has a great day. Before you leave, please answer the 6 questions that have just popped up on this poll. We use information feedback from webinar participants to improve our webinars going forward. So we'd love to hear what you think. And also looking forward to continuing this conversation for everyone who's interested. Best wishes to all for a great day, evening, or afternoon.